Well, hello out there in computer land. Welcome to Rising to the Challenge of a Pandemic, a conversation with experts brought to you by Alaska Airlines. I'm Luke Burbank. I'll be hosting things tonight. I work on a variety of public radio shows, including Wait, Wait, Don't Tell Me. I also work on CBS Sunday Morning, but probably my greatest resume achievement is that I am a member of the Alaska Airlines Mileage Club, which I'm very proud of. So I was excited when they asked me to help out with this event tonight. I don't think I need to tell you that things are quite unique in this moment of our life. The fact that we're doing this on screens tonight is all the indication you need to that point. And you got Thanksgiving, it's like 2 days away, and then all of the other holidays. And this is the time of year when we're really thinking about being with friends and family. But there's sort of no way around it that it's going to be different this year. So this is the plan for tonight. Alaska Airlines wanted to get together two of the leading research organizations in the world, which both actually happen to be in Seattle, the Fred Hutchinson Cancer Research Center, and also the University of Washington Medicine, to talk about COVID, to talk about the latest developments, to talk about where we are with the science. And so we're going to do that. And you're going to get a chance to ask some questions as well. We're going to be going over a bunch of stuff, including how do you stay as safe as possible? What should you know about testing? And also, what is the truth about vaccines, which seems to be something that can be a little elusive these days, the actual scientific truth around a lot of this stuff. So we're going to get to question and answer in just a bit, but first let's introduce some of the experts who are going to be helping us out tonight. Let's start off with Dr. John Lynch, an associate professor of medicine at the University of Washington School of Medicine and an associate medical director at Harborview. Dr. Lynch oversees the infection prevention and control programs. And also, Dr. Lynch, you've been advising Alaska Airlines on infectious disease for the last 7 years. So this is something that you have been giving a lot of thought to as it relates to Alaska Airlines. What sort of information have you been sharing with them recently?
Yeah, thanks, Luke. Well, you say recently, when I really think about it, it's been a long journey since we started talking about this in January when Alaska really got engaged. I think, like many of us in the United States, but particularly for airlines, about how folks were moving throughout the planet, especially from China and parts of Asia where the COVID-19 was first rolling out. And really, since then, it's been an ongoing conversation that I would say is evolved over time. And as we go through this conversation tonight, I think that's going to be an important concept. We are constantly learning about what's important to prevent transmission in a huge variety of circumstances, from our homes to airlines and airports and buses and trains and office buildings. And I think that's really been the focus of the conversation most recently, taking what we've learned over time and putting it into place in places like airplanes, airports, and similar other areas.
What's the role that air filtration and ventilation play in this whole thing, particularly like on an airplane?
Yeah, perfect, because this is exactly one of those areas that I think anybody who's been following the media around COVID-19 knows has been one of those key areas of evolution. How does COVID-19 or the virus SARS-CoV-2 get from one person to another person? Early on, we thought it was mostly these droplets, these heavy, wet particles that we cough or sneeze out, and those land on other people, or we touch them on surfaces and we touch our mouths, our nose, our eyes, and transmit the virus to ourselves. Over time, what we've learned, it's still that, but it's also some of these really small particles, these things that float in the air. Sometimes people call them aerosols or small respiratory particles. And what's really important about that is that, unlike droplets, those things can be filtered out when we move air around. So when you think about volumes of air, you're thinking about dilution of those particles, right? The greater the air volume there is, the fewer particles there are for you to inhale. But as air is being moved through circulatory systems, like on airplanes or buildings, moving through filters is an additional really important step to get rid of many of those small respiratory droplets as they move through the facilities.
All right, Dr. Lynch, if you can stay right where you are, we're going to come back to you in just a moment. Though, first, speaking of the air ventilation and all of these different elements that Alaska Airlines is trying to bring to bear to keep people as safe as possible on these airplanes, let's talk to Josh Nice, who is Alaska Airlines Director of Safety and Quality Assurance. Josh is part of the safety team that's been making sure that Alaska's planes and offices and airports are safe for us, the travelers, and for Alaska employees. Josh, a big question on everybody's mind, especially with the holiday here. Is it safe to fly?
Hi, thanks, Luke. Thanks for having me. To answer your question, is it safe to fly? Yes, it is safe to fly. As Dr. John Lynch just mentioned, there are a lot of layers that are protecting us. I'd like to bring up that Alaska Airlines, especially if you haven't flown in a while, you should know that there are over 100 layers of protection that we've incorporated. As a safety geek, I'll try not to go into too many, but I think some of the ones to feature when you walk into the airports is our mandatory mask policies. We all know the mask is a critical control barrier. You'll also see at the airports physical distancing reminders. A lot of our processes have moved to touchless ones. We have cleaning before every single flight. And as John mentioned, Dr. John mentioned, we have our HEPA filters on all the aircraft. These filter out 99.9% of particulate contaminants, including the coronavirus. And then that, coupled with the rapid airflow from top to bottom on our airplanes, allows for a refresh of air every 2 to 3 minutes. Compare this to 83 minutes for your office place, and even more for just your indoor environments at your house. I believe it's about 280 minutes. So studies that have backed this have come out from credible sources like DoD, where they've ran a very thorough simulation on aircraft. And so much so that I've told my family that for Thanksgiving, we should actually gather on an airplane. So from my standpoint right now, yes, it is safe to fly.
You must be, like, just in your civilian life, having so many people just ask you questions like this all the time, because like you're kind of the point person for trying to keep people safe up there. What about the topic of eating and drinking on board? Is that safe?
Great question. Definitely something that we have considered. If you've traveled on us, you've noticed we've significantly reduced our food and beverage service on board aircraft. However, we have returned carefully some of our services. That's with consultation from Dr. Lynch, and also after we conduct a thorough safety risk assessment, which is part of my world. We gather together with the right people, and we actually think of the mitigations that will help keep our guests safe. Some of the things we've incorporated out of those safety risk assessments include like a menu card. We've redesigned the menu so that you can keep your mask on to order. You point to the item you want, or you give a number signal with your fingers on what item you want to order. We also have restricted our purchasing to pre-order, so you're not interacting with money or anything on board the airplane. Another concept is recommending that guests sip and cover, which is basically if you're not actively eating or drinking, we will kindly ask you to keep your mask on. Speaking of mask compliance, if we have a guest who's not complying, we do have some tools. We have the gentle verbal reminder, but then we also have a written card. It's called the yellow card, like in soccer. And our flight attendants and flight crews can use those as kind of a last resort tool if a guest is refusing to comply.
So can other passengers play a yellow card, or is that left to the Alaska flight?
It's the Alaska flight crew,
right.
And it's definitely not something you want to brag about getting.
Okay. Josh, thank you. Stand by, because if we have a question come up in the Q&A, that's something that as our Alaska Airlines representative, you can answer. We will be leaning on you for that. Let's bring another medical expert into the conversation, Dr. Keith Jerome, who is a virologist at Fred Hutch and the director of the University of Washington's Molecular Virology Laboratory. And thanks to Dr. Jerome's team's work, the virology lab at the UW School of Medicine has done more than 1 million COVID-19 tests since early March. Dr. Jerome, thanks for joining us.
Yeah, my pleasure.
1 million COVID tests. That sounds like a lot. Is that a lot?
That's a lot. And I will tell you that the people in the lab and in our program who've worked so hard to do this, they're really the unsung heroes. They work in a lab, across town, and they never get to see the grateful patients or be thanked. But people are working incredibly hard, and we got a nice Twitter shout out from the governor, Governor Inslee, when we hit 1 million. We're already well over 1.2 million. Things are just not slowing down whatsoever.
I understand that Fred Hutch and the UW created their own COVID test last February, and this was like before the CDC was really able to scale their version up. How did that affect Washington State's response to the pandemic?
Yeah, well, we were actually following this, Luke, back at the end of December when there were the initial reports out of China about this virus, and the sequence came out, the letters that actually make up the code for the virus, that came out in early January, and that's when we started. And so through February, we were actually working hard and ready to go. There was a bit of a story that unfortunately we weren't allowed to actually use the test through the month of February until the last day of the month. But what it did mean is that we were there and ready to go. So as soon as we were allowed, we had a test ready to go, and we were, all cylinders were firing from day one. Thank goodness we started preparing early because we were the place where the virus came first to the United States.
What are I guess the sort of short version, what are the different kinds of tests that are out there and that are effective right now?
Yeah, well, I can certainly give you a long version of that too, but I won't. There's two big categories.
Give us the scientifically accurate version as opposed to something that someone's uncle posted on Facebook.
Oh yeah, there's a lot of misinformation out there, for sure. So there's two big categories. One is looking for the virus. Do you have COVID right now? And that's usually the swab up your nose. Sometimes it's saliva, different things. And then there's a second category where they take blood, and that's actually looking for the body's response to the virus. That doesn't come typically for a couple of weeks after you had the infection. So we can look backwards. Somebody says, hey, I had this thing in the spring. Was it COVID? We can go back and look and tell you yes or no. So most of the tests you're getting, when you go and you want to get screened, maybe you have symptoms, you get one of these tests looking for the virus. And then there's a bunch of different things within that. You'll hear a lot about PCR tests. Those are sort of the gold standard, the best tests, really accurate, very sensitive. There's rapid tests, there's antigen tests, and all these have different levels of performance that it takes really professionals to dig through and actually figure out how well does a given test perform. And once we know that, where's the best place to use that test so that it actually does the most benefit for what that test can achieve.
What do you think the future of testing looks like? I've heard about, some home tests that people now may be able to do. I mean, where is this going to end up in your professional opinion?
Yeah, there is this home test. It's not broadly available right now, only in a couple of areas of the country in defined medical practices. It'll be a few months before it's widely available. Home testing would be great. That test costs about $50 a shot, which means you're probably not going to do it super often. There's a couple of things. First of all, labs like ours continue to grow capacity to do more and more. We did over 13,000 earlier this week in a single day. We're pooling, so we can actually combine. If we think these are relatively low risk people, we combine them into one test, and if it's negative, everybody's negative. If it's positive, we go back and figure out who was the positive person there. But I'm really excited about our really inexpensive tests that can be done at home, where you could actually think financially about being able to do it every single day, so that we can really catch infections early. The problem here is people become infectious before they feel sick, and that's why this virus is spreading so well. It's very hard to catch those folks. So if we have tests like that, and there is some technology out there that promises that, it might be an additional way that we could have another layer of protection like we were hearing about. Just more to tide us over until I think we get these vaccines in hand, which is really going to be our way out.
Okay. Well, speaking of which, we have another expert waiting in the wings. Dr. Jerome, just stay where you are too. Let's bring Dr. Michelle Andrasik into things here. Dr. Andrasik is Director of Community Engagement for the Hutch-based HIV vaccine trials network, and also for the 5 COVID-19 vaccine trials that are being coordinated by the Hutch. And Dr. Andrasik's work has focused on HIV prevention and the social and structural factors that cause health inequities. This has been a huge part of this story, is how much harder this has hit communities of color. Dr. Andrasik, thank you for being here.
Thank you for having me.
Can you explain what the Hutch's role in managing the vaccine trials kind of is, and and how they're sort of the authority on vaccine coordination?
Yeah, so we have been coordinating HIV vaccine trials for several decades now. So we have a really well-established infrastructure to move the trials forward. So we are doing central operations, tasked with community engagement, and site clinical research site support. So we are taking sort of our longstanding relationships that we formed in the decades of HIV vaccine research and coordination and utilizing that infrastructure to move the COVID vaccines forward.
What is the status of the vaccines?
So as many of you have seen, both the Pfizer and Moderna vaccines have shown 90 to 95% efficacy. I think it's really critical to understand, though, what that efficacy means. That efficacy is showing prevention of severe disease progression, not at this time prevention of infection. And I think that's an important and critical point. So what we know now is that the two messenger RNA vaccines that are being tested by Pfizer and Moderna are 95% effective in preventing severe disease progression. So when you are infected with SARS-CoV-2, the virus that causes COVID disease, your chances of progressing to severe disease, which require hospitalization and potential death, are greatly reduced. So later, when we see an emergency use authorization, what we will likely see is that the distribution and dissemination of vaccines will be targeting those individuals who are at greatest risk of exposure and severe disease progression. So frontline workers, people who are older, 65 and older, and so forth.
So when we hear this news, which is very promising around a lot of these vaccines, that they're being developed and that they are showing efficacy, we should temper that with the kind of realistic timeline of when it will be widely available to, radio hosts, people like that.
Yes, exactly. And I think it's incredibly promising. I mean, these efficacy results show that, our focus on targeting the spike protein of the SARS-CoV-2 virus is probably the right way forward. But I think we also need to keep in mind that we still don't know and won't know for quite some time whether or not the vaccines prevent infection. So it is, likely that we can still be infected with SARS-CoV-2 with these vaccines. And if you are infected, then you can still transmit the virus. So I think, that it's really important for people to keep that in mind, that we're still going to have to wash our hands. We're still going to have to wear our masks and physically distance for quite some time.
There is in this country a fair amount of suspicion around things like vaccines, despite what seems to be their pretty clear beneficial effects. What do you tell people when they ask you if these vaccines are safe or how you can be sure that they're safe?
Well, we have lots of information about the safety mechanisms that are in place. So I generally start there with the safety mechanisms that we have in place, the data safety and monitoring boards, and discussing all of the various ethical rules and regulations that have been put in place to address some of the unethical behaviors that have happened in the past. And I also underscore the fact that individual scientists historically have been unethical, and science has done a lot to ensure that there are checks and balances in place so unethical behavior cannot move forward. forward, unchecked. And I think that that's really critical. We point people to the Helsinki Declaration and to good participatory practices and all of the various strides that we have made in science to ensure an ethical way forward for all of us.
So you feel there are a lot of sort of institutional controls that are there to make sure that one or a couple of bad actors can't actually put something out to the public.
Yes. And I also know from my years in science that there are way more, infinitely more ethical and morally compass-driven individuals than there are the unethical individuals. So just from, anecdotally and, in terms of what we have in place, there are many checks that ensure safety and ensure, and work towards inclusion as well and diversity in our trials.
Which actually is the next thing I wanted to ask you about. I know a big focus of your work is really trying to create a diverse group of people participating, in studies and development of various medicines and vaccines. Historically, why has that been such a challenge, or what are the things that are sort of structurally have been working against more people of color in particular, getting the treatment that they deserve?
Yeah, well, this goes back to your previous question. The indigenous, racial, and ethnic minority communities in this country that are hardest hit by COVID-19 and, numerous other diseases share a legacy of abusive policies and practices that not only create social and economic circumstances that compromise their health, but compromise their general well-being. And this reality is coupled with the fact that these communities continue to experience economic marginalization, and there's a relative lack of inclusion and representation in science and medicine, which have fostered a mistrust of medical and research establishments. And what we have found to be true is one way to overcome that is actually including individuals in research efforts. Not only does it increase knowledge and familiarity with the research process, but it builds relationships between community members and research institutions. It increases the availability of important resources for the larger community. And I think most importantly, it cultivates trust in research. And we've seen that in HIV research. We're seeing it now in COVID research. And, I think to underscore one of the critical factors that we find to really move the needle towards trust is providing resources and information for communities so that they have what they need to make informed decisions about their health, the health of their families, and their communities. And that's been incredibly challenging with the politicization of the vaccine efforts and COVID generally.
I know that one of the things we were hoping to accomplish tonight was to encourage people, of all backgrounds, particularly though people in marginalized communities, to, if possible, take part in these things for the reasons that you're pointing out. Do you have a piece of advice for the various folks who are, watching this from wherever people are watching this, as far as how they can participate?
Yeah, the best way to do that is to go to preventcovid.org. We have a registry there. On every page, you'll see a little button that says volunteer now, preventcovid.org. And we ask you to take a very brief survey, which will help us determine your risk factors and be able to identify if you're a good match for any of the vaccine products that are currently being tested. And then one of our sites will reach out to you in your area, and I think it's critical, especially for those of us who are in hardest hit areas. We really need individuals who are from hardest hit communities so we can understand the efficacy of these products on communities that are hardest hit. So it's really critical Particularly if you have, you're around people a lot, and so your exposure is high, you would be a very good match for some of the research that we are doing now in the CoVPN.
All right, so if you're watching this right now and you have that generalized feeling of helplessness that all of us who don't work in medicine or epidemiology, I think, feel a lot of the time right now, this is a way that you could you could feel like you were maybe taking back some of that control and helping us all get to a solution, because I think we're all pretty ready for this pandemic to be over. I think the folks watching this, wherever they are pretty ready to start with the question and answer phase. So that's what we're going to do. We're going to take your questions. I believe in the chat function there, you can see where the button is to ask a question. We sent an email out a little bit earlier soliciting questions, and I think we got like almost 1,000 questions. So between those 1,000 or so questions and what folks are going to be sending in the next half hour or so, we're not going to get to everyone, but we'll get to as many as we can. Also, some of those questions will be answered on the Alaska Airlines blog coming up. So if you submit a question and we're not able to get to it tonight, there still may be a chance for you to get that question answered. I see, by the way, before we jump into the Q&A though, Dr. Lynch, I see by this delicious graphic that they're putting up on the screen, there is something called the Swiss cheese virus defense that Alaska has been putting into place. Can you explain what that actually means?
Yeah, sure. So I think a lot of people think about, these sort of multi-layer models or these Swiss cheese defense. I know the airline industry uses this model all the time, and a wonderful virologist by the name of Ian McKay in Australia sort of crowdsourced this, and he's actually got one now that's, I think, 15 or 18 layers deep, split into personal responsibilities and society responsibilities. But this one, I think, really goes to the questions that I think may come up around how safe is an airplane, how safe, is an airport. And it goes back to Josh's point that it's, this isn't 100 layers like Josh is talking about, and there are many, many layers, but these are some of the concrete layers that I think about when I think about how do we make flying safer. And I want to really emphasize, it is not one thing. It's not even masking by itself, right? We focus a lot on masking. In the hospitals, we focus on, eye protection and so forth. But it's everything from the time before you leave your house to you get to your destination and back. How do I feel that day? Hoping, we don't want people to come to the airport not feeling well. Are you taking, mass transit on the way to the airport? How much time are you spending in the airport? Are you eating, you drinking, right? Are you in crowded areas getting your tickets or something similar? What is it like going through TSA? What is it like on the plane itself? Where does testing fit into all of that? Like we know about Hawaii and Alaska right now. What is the spacing on the planes? The touch-free innovations that Josh just talked about, right? Not handing things back and forth, no cash, no menus, are all really important parts. And when you line up many, many, many layers, right? And this is actually, a subset of those layers. When you add up lots of layers, that's where you see effective reductions, and we hope in many cases elimination of transmission between individuals. And so this is the Swiss cheese model. You line it all up, and you hopefully never, if you have enough of these slices, the holes never align and the virus can't get through. But that's really the important take home. It's no one thing is going to get us through this. Testing or masking or even the vaccine that Michelle's talked about. It's a lot of things all the time going forward.
We have a question that's come in that Dr. Jerome, I think, could answer. This person is wondering, they say their son lives abroad. He had COVID a month ago and has recovered. If he's exposed to COVID while traveling, can he be a carrier for COVID, infecting other people, even though he has antibodies? If so, how long would he need to quarantine? Do you have a thought on that, Dr. Jerome?
Yeah, we're still trying to understand what it means to be protected by having COVID. We're learning that there is some protection from that for sure, and that informs what we think getting a vaccine will be. And so I think the unfortunate answer is we're not completely sure. I think the likely answer is that's going to provide him some protection from getting sick. it probably keeps him from making as much virus as he would otherwise if he does get exposed and infected. But we just don't know enough to be sure, and we don't know enough to be able to say there's no risk in that. And so, again, you sort of get back to this Swiss cheese model. Maybe that is sort of a layer of Swiss cheese that's a little bit of protection, but it might have some holes, and we just don't really know how big those holes are right now.
This is a question that came in actually for Josh Nice, our Alaska Airlines safety expert. This person wanted to know what all on the plane, inside the plane, gets washed down. Like, what is the process for making one of those airplanes as safe and virus-free as possible?
Yeah, thanks, Luke. Yeah, to cover what we clean on the airplanes, I think it helps to go back and just say that we took a holistic view at all of our cleaning processes as a result of COVID. The turn process, that's the time when the airplane's on the ground. We didn't typically, spend a ton of time cleaning, but now we do a thorough cleaning of all the surfaces that folks will be touching, especially focusing on using elbow grease. As Dr. John Lynch has shared with us, the virus does not like when you scrub it. So we use elbow grease on the high touch point areas, such as the panel above your head, the armrests next to you, and any of the areas that you might be, the tray table, any of those items that you might be touching, even the seat belt. What's for the overnight, when we have more time with the airplanes, we do a very thorough cleaning of all those touch points and the carpets and the other areas that we didn't cover during the turns. And I'm actually excited to share that we have found a chemical that's safe to use on the airplanes that actually protects the airplane from the COVID virus from living on surfaces for up to 24 hours. And we will apply that with an electrostatic cleaner for all of our RON, we call it Remain Overnight aircraft.
Oh, wow. What is that thing called? Do you know the name of it?
Yeah, it's Biotrol 24, I believe, is the official name. And
that was my guess too. I just wanted to see if you knew the name.
Okay.
You passed the test, Josh. Here's a question that came in for Dr. Andrasik. If a person has one type of COVID-19 vaccine, would it be okay to have a different type of COVID-19 vaccine later? What would the ruling on that be, Dr. Andrasik?
Currently, we are not aware of how the vaccines will interact. Certainly, if someone is in one of our trials, we are asking them not to join another vaccine trial. And there are so many more questions than answers that we have at the moment. And I think, as we get further along and we see the immune data, and I want to just point out that what we're seeing now is interim data. We only have one vaccine study in the US that's fully enrolled, and not everyone in that study has completed even their second vaccination, and none of them have completed the follow-up period. And then all of the other NIAID-funded studies are currently being enrolled. So there are many questions that we still have to answer. And as we get the data, we will be able to answer these. But unfortunately, at the moment, we cannot answer them. But we would advise not to take more than one vaccine at the moment.
Okay. I mean, if you're lucky enough to have access to any vaccine,
right.
I mean,
exactly.
you're really somebody special, I guess, if you've got your pick of two. Here's a question that's come in that maybe Dr. Lynch, you'd be able to answer. Someone's asking, there's so much focus on cleaning, but yet it seems that there's little evidence for contacting the viruses by surfaces. Is all this expensive and laborious cleaning? I feel like this question is a bit of an assault on Josh Nice, but we're going to leave that out of it. Is all this expensive and laborious cleaning really necessary?
Well, as I mentioned before, this conversation, the watchword has been evolution. We learned about this early on. The conversations that we had with the Alaska Airlines team was to, let's go for all of these possibilities, from masking to distancing to all the other tools that we've got in place. The Alaska team, I think, did a great job. Josh has actually been a little bit humble. They got a lot more people doing this work, working a lot faster. I was able to go down and watch these teams work on planes, and they're really effective in turning them over and getting the cleaning materials and the elbow grease, as he said, to lots and lots of surfaces. You're right. We've learned now that probably what's called fomite or contact transmission is probably a much less of an important role, but it's not zero, right? This is why hand hygiene is still super important. We should still all be washing our hands frequently. And we also have to remember that planes have people move through them, right? You have one flight and then another flight. And I think that, when we think about those situations, unlike, say, sitting in an office or something similar, cleaning between people's presence still makes some sense. And if it is part of that Swiss cheese model, right, it's one more, maybe it's not the thickest one, maybe it's not the one with the fewest holes, but it's still, I think, an important part of the whole process.
Here's a question that Dan submitted for Dr. Jerome. It's a sort of a basic question, but I mean, it's a very important question. If you think you might have been exposed to the virus, how long do you wait to get a test?
Yeah, well, one thing to remember there is there's not a perfect time. This is a tough question, and a real world question is important that we deal with. And so we sort of give ranges. The issue here is that if you test too soon after you've been exposed, even if you're infected, there's not enough virus for our test to detect. So we're trying to wait until there's enough virus for the test to become positive, but still get it early enough so that it's useful to you and that you make it. You make the diagnosis. So usually we tell people that sort of the sweet spot is 5 to 7 days. That's where if people are infected on average, they're starting to actually get sick. That's when the virus is at the highest level. So you're likely to see it. But even waiting that long, it's not a perfect test. And some people have clearly become detectable later than that. So that would be too early for some, but that's sort of our best advice as to when is the optimal time to go.
Is that kind of, I guess, imprecise timeline? Is that part of how false positive and false negatives come about? How do those happen?
Yeah. So, those of us who actually run those labs sometimes chafe a little bit at that idea of false negatives. That, early on, there probably is really, immediately after infection, there's essentially no virus there. It hasn't actually begun this process of replicating itself and making all these copies that we can detect, then ultimately go on to infect other people. And any laboratory test that we perform has limitations. They're not perfect as much as we wish they were. There has to be a certain amount of virus there to detect that. If you're infected, but you have less than that, we just won't see it. If the person
so it's not
doing
a false
the swab,
negative. It just doesn't rise to the level of detectability.
Yeah, oh, for sure. So there's a biology there. Now, there are truly false negatives. Something, things can happen. The person doing the swab doesn't get that, doesn't do it vigorously enough, or, puts the wrong one in, puts in the wrong tube, mislabels things. There are things like that. They're rare. We have processes to prevent them. They're kind of analogous, I think, to some of the things the airline industry has actually pioneered. The medical field's learned a lot from error reduction from the airline industry. So we reduce those. But there is biology, and there's biologic variability that makes this an imperfect process to diagnose the infection.
I was having a test done a little while ago, and I have to say the person was being fairly gentle with my nostril, and I was appreciative of that. But I also was wondering if it was going to be fully accurate because of what was not that uncomfortable of a process.
I understand the mixed feelings for sure.
Yeah, right.
On a good test. So,
yeah. Here's a question for Dr. Andrasik, because you've worked so much with HIV, Doctor. Someone wonders, how does the vaccine work in unison with people living with HIV and AIDS and their current medications and those with pre-existing conditions?
Again, we don't have enough data to say anything about that. As you may know, we are focusing on individuals with pre-existing conditions because they are at high risk for severe disease progression. So certainly people living with HIV are, a priority population in the work that we're doing in COVID. And again, we will need to see what the interactions are with medications that are being taken, just as we will with any participants who have a pre-existing condition.
Okay. Here's a question, maybe Dr. Lynch, that you'd be able to answer. Somebody is wondering, how long does the antibody remain in your body? Can you be tested still today and get accurate results for the antibodies you might have had back in March? There seems to be a large amount of the US population, I know many of them, who are pretty sure, at least in their own theories, that they had it before we were talking about it the way we talk about it now, and they wonder if they have antibodies. How long do the antibodies stay in your body?
Yeah, I think I'm going to tag team this with Dr. Jerome, if you don't mind, Keith. So, remember, we are coming up on a year of knowing anything about this virus and this disease. And so that's how much data we have. Antibody, data didn't come out until a bit later. What I've learned in our UW medicine work, we did a big study of all of our healthcare workers during the summer. And in that process, we definitely had people who had positive tests in the spring and had negative antibody tests in the summer, and people who never remembered having an illness who were positive in the summer. And we know that from various observational studies, these are studies that just collect data, not in a forward-thinking way like the ones that Dr. Andrzejczyk's working on, but really looking at what's happened in the past. And we know that in healthcare worker populations where a lot of these antibody tests have been done, a large number of them seem to lose their antibody positivity within months of their initial infection. Having said that, we'd still have lots of people out there who have positive antibodies for months and months and months. So with that observational perspective, I don't know, Keith, what you'd like to add to that.
Well, I think you've summed up what we know pretty well, John. I mean, it's very clear. We've followed sets of people over time, and the antibody does, we say it wanes. It just means the levels go down over time. And for some people, they do become undetectable. Those are often people who had more mild COVID. There seems to be some association. If you were very, very sick with it, your body makes more antibody to fight it off, and it lasts longer. So the antibody can certainly last for months. I think it's likely that on average it's going to last 6 months or more, but some people will be more, some people will be less. One thing that's important to remember is don't get too pessimistic about this idea that the antibodies go away. The antibodies are only one part of the way the immune system fights against the body, and there is emerging data that a different kind of immune cell called a T cell actually can live longer and may provide substantial protection for a much longer period than the antibodies alone. So we really don't know, if the antibodies go away, you may still have some protection, and we really need to figure that out, but we just haven't had enough time to follow that yet. It's a very important question, and lots of people are working on it very actively.
Here's a question for Josh Nice from Alaska Airlines. How often is Alaska replacing a cabin air with outside air? And is that something that varies from airline? Is it an industry standardized thing? How often is that air sort of swapped out?
Yeah, thanks, Luke. So the equation's a little bit confusing as maintenance describes it to me, but basically the engines are drawing in a combination of outside air. When you're at altitude, you can't breathe in that oxygen, lack of oxygen air, but you are also getting the HEPA filtered air simultaneously. What I feel comfortable quoting them as is that you're getting that refreshed air every 2 to 3 minutes, but 100% outside air after 6 minutes. Again, that's dramatically short time period compared to other environments that we are in outside of an airplane.
Okay, that's good to know. Dr. Andrzejczyk, here's a question. Well, one, just on a practical level, somebody is wondering if volunteering would involve a drive to Seattle. Do people have to go somewhere to be part of the research that you're working on?
No, we have over 200 sites around the country, and we have 3 actually in Seattle. And yes, in Washington State, the 3 are located here in the Seattle King County area. But one of those sites has a mobile unit that they are utilizing to go out into communities so that communities won't have to make the drive into Seattle. And again, the best way to get matched with a site that's near you is to go to that preventcovid.org and sign up for the registry and have someone give you a call back.
Okay. Here's another question, Dr. Andrzejczyk, for you. Somebody is wondering, do you see any of the vaccines that are currently in the pipeline as actually preventative? And when will the current vaccines enter the peer-reviewed process, or will that be bypassed? And then they said, thanks, Alaska Airlines, for this great webinar. So you're welcome, whoever that is. But more importantly, Dr. Andrzejczyk, are any of these vaccines, do you see any on the horizon that are preventative?
Well, I think it's important to remember that the primary objective of these vaccines is the prevention of severe disease progression. And the secondary objective is prevention of infection. We won't, however, know if the vaccines prevent infection until we have more data over a longer period of time, because we need to look at the immune response over, a significantly longer period of time. So we're hoping that sometime in early next year, and I don't want to make any promises, but that's what we're hoping, that we'll have the data. And the really great thing about these trials and why it's so important to get people enrolled is that, the more people we have and the more outcomes we see, the better able we are to look at the immune response to the vaccine. So, those of us who are doing HIV research are used to these sort of 5,000 person trials. So these 30,000 people trials will help us get there a lot quicker.
This is a question that I have been curious about myself. I think we probably all are as we move through the world these days. This might be one that Dr. Lynch could answer. Somebody is wondering, how important is wearing the right kind of mask, or wearing a single-use mask only once, or washing a cloth mask that is not washed every day? I guess the kind of nature of the question is, are all masks created equal?
I think, Luke, you cut out, but I think that one was for me. Is that right?
Yeah, sure. If you don't mind grabbing this, Dr. Lynch. Yeah,
no problem. Yes.
Did you hear the question?
I did. I think. Please steer me right if I go off in the wrong direction here. But yes, when we think about the filtration properties of all the different materials we are wearing over our mouth and nose. Important to remember, mouth and nose, both of those count. None of the nose peeking over. Those they do have different filtration, and we have to also recognize that medical masks, and you may have heard about these respirators, N95s and higher, they have a combination of both mechanical properties, so the way they're built, but also things like electrostatic properties and fluid resistance properties that add, greater layers of protection. Now, I would say that, the data is swung all over the place over the past 6 months, from, cloth masks and neck gaiters don't work to, oh, yes, they do. What I would say is that all of these face coverings, from both the technical to the non-technical, do interrupt both transmission and acquisition. So both prevent stuff coming out of someone and infecting someone else, but also me getting infected. So it's, as someone said who is much smarter than me, wearing a mask is a message of love, right? It's showing respect and humility and love for your neighbor, and caring for yourself. And any of these things are going to be helpful. And as you do go up that hierarchy, they're going to get better and better. And that's why in hospitals, in clinics, and in vaccine studies, they're wearing medical masks. And in some cases, wearing the respirators for additional protection.
Got it. Here's a question, Dr. Jerome, for you. And I'm going to be honest with you. This has already exceeded my knowledge around the COVID virus. So I'm obviously this person watching us wants the answer, and I'm going to hope you know the answer. They write, esteemed scientists. I'm really teeing this one up for you. Esteemed scientists and even Dr. Fauci's own study says that the PCR should not be used to diagnose because it is amplified so greatly that it'll give overwhelming amounts of false positives and can't be distinguished between when you are contagious or if you've had any coronavirus at all. If the test is faulty, then the data is flawed. What is your response to that question/statement?
Yeah, well, there's parts in there that are true, and then there are parts that are probably overinterpreted, just to put science speak on it. So it's very clear that the PCR tests are extremely sensitive.
What are the PCR tests for those of us?
Sure. So PCR is the jargon we use. It stands for something called polymerase chain reaction, and essentially, if you have really anything you want to detect that has nucleic acid in it, DNA or RNA, you basically take a little tiny region, not the whole thing, just a little region that's within what you're interested in finding. Maybe you've seen this in some of these like crime shows, right? You want to see DNA from the criminal. Well, in this case, the virus is the criminal. It's just a little tiny piece of it. And essentially we amplify that. It means we take, if the virus has 100 copies in somebody, we turn that into 1 million and then 10 million. And as the number of copies of that little tiny region increase, we can detect it in our instruments. It actually glows, it fluoresces. So our instruments can see that. That little piece isn't infectious, so we're not making more virus, but it allows us to detect it. So the issue here is that because we can amplify 100 copies into 1 million, we can also amplify 10 copies into 100 million. So the question is, are 10 copies of something actually infectious or not? And for certain viruses, it's just critically important to get every last one. For HIV, for example, we want to know, is there any virus there whatsoever? And so we ramp the tests up as much as we can. For COVID, what we've learned through the process is that, particularly in the people on sort of the backside of the illness, they've gotten better now. They want to get out of the hospital. Early on, we were saying, well, you can't leave, you can't go see anybody till your PCR is negative.
Okay.
And for some people, that took a really long time for that to happen. There were little remnants of just enough virus to detect. What we learned over time was they weren't infecting anybody, basically. So some people say, oh, that's dead virus. Maybe it's dead, maybe it's fragments of virus, maybe it's just not enough to ever cause an infection. So we've really learned to look at how much virus is there, and to really not overinterpret what we're finding. So, we're learning as scientists. We try to be humble. We try to not say we have all the answers. And what we learn and think we know is always subject to change as more information comes along.
All right, we have time for one more question. And I guess because we started things off with Dr. Lynch, we're going to end things with him in the sort of bookending things fashion. This is from someone who asks anonymously, are there any treatments that our doctors can easily prescribe that minimize the impact of the disease if we get COVID?
Yeah, sure. I'm going to answer that. But just to follow up on Keith's comment, the other thing that's really important to recognize is that as we're seeing more people with positive tests, in UW Medicine, we're seeing more people in the hospital with COVID-19. A few weeks ago, we were about 20 patients in our system per day, and we're now up over 80 patients per day. And you can see that trend follows the positive tests. So these tests, yes, they are incredibly sensitive, but when interpreted correctly, are incredibly meaningful and incredibly helpful for diagnosing patients and figuring out who needs to get treated, which is your question. So we've gone through a lot of potential treatments this year. Again, a lot of this has been in the media, azithromycin, hydroxychloroquine. More recently, we've been using this drug called remdesivir, which is a drug that's really focused on treating viruses specifically. And the other one that's in common use for now is called dexamethasone. It's a type of steroid. The remdesivir drug, we've seen some signals that it's very helpful. Some newer studies, more recent studies, not so compelling. And some of the national and international bodies that make recommendations around treatments here in the United States and elsewhere have, as they've gone through time and gotten more data, have felt less compelled to recommend that particular drug, including the WHO, which currently doesn't actually recommend the use of that drug in the treatment of people with COVID-19. So we don't know where that really stands right now, though it's in common use. Dexamethasone is a drug that's being used in people who are severely ill. Often people go into the ICU who require high levels of oxygen. And again, we think it does appear to help. We're going to need more time, but both those drugs are in common use. There are lots of other candidates out there. Some of those drugs, like azithromycin, hydroxychloroquine, have been proved very definitively to be not helpful in the care of patients with COVID-19, including great studies done here in Seattle. And I'm sure there's more drugs in the pipeline to look at in the future, hopefully drugs that target this virus specifically. But right now, I think the thing that's probably making the most difference for patients is the bedside clinicians, the respiratory therapists, the nurses, the critical care doctors, acute care doctors, who have learned how to take care of patients, learned how to check oxygen levels, when to give oxygen, when to put people on their bellies, what we call proning, and when to, put tubes in people in their throat to help them breathe. And I think all that clinical knowledge is really what we're seeing help patients more than anything else right now.
And then there's just all the stuff that healthcare providers are learning that's on the maybe less medical but more human level. I for my TV job, interviewed a doctor in Pennsylvania who started putting a picture of himself on his PPE, because he's dealing with people who are seeing someone in this very imposing outfit, and just that thing of seeing a human face that the patients could identify with being inside of that PPE. Those little things are these amazing, ingenious ways that medical professionals are just figuring this out as we go along.
Yeah, the humanity that frontline healthcare workers and all the support staff are bringing to the care of their patients in the midst of this pandemic is astounding. I'm a healthcare epidemiologist. I'm a programmatic operational person. I'm not at the bedside. My job is to keep them safe, and I'm continuously inspired by the folks at the bedside. But to be clear, I'm also wildly inspired by the scientists, by the folks doing the vaccine studies. The stuff that's working that the lab is doing. I could spend hours talking about how incredibly life-saving the tests that lab medicine team has put together, and how that really saved us, early on and continuously right now. And I can't wait to 2021 and Dr. Andrzejczyk's work being out there in the world to help stem the tide of this pandemic. It is a wildly tiring, exhausting, and inspiring time to be in this field. So I'll stop there.
Yeah. Well, Dr. Lynch, thank you for everything you've been doing, and thanks for being part of this conversation tonight. Also, big thanks to Dr. Jerome and also Dr. Andrzejczyk, and to our friend Josh Nice from Alaska Airlines. Thank you to everyone who watched and submitted questions. Again, if you didn't get your question answered, some of these questions will get answered at the Alaska Airlines blog in the next, I think, few days. So look for it there. Also, if you want to get more involved in the Hutch's research or subscribe to get news alerts, you can go to fredhutch.org/sign up. So that's a little bit of useful information for you here at the end of what has been a lot of really good, useful, scientifically based info, which is always nice to have during a pandemic. Thanks again. Please have a great holiday. Stay safe, take care of yourselves, and remember, we're going to get through this together. Have a great night, everybody.